Hi, can you hear me?
Yep, we can hear you, Matthew.
All right, excellent. Victoria will be setting up the slide shortly, and then we can begin.
Sure, please.
All right, are we ready? 1, 2, 3. Just today, you probably got up from a chair or climbed a flight of steps without a second thought. You and I may do these things effortlessly, but it's not so simple for our elderly. In fact, 4 in 10 of those aged 70 and above suffer from knee osteoarthritis. That's a terrifying statistic from Singapore, where half our population is expected to be older than 65 by 2050. Good morning. I'm Matthew and I'm part of Team Neoni, and we are reinventing mobility for patients with stage 1 to 3 OA. Over the course of this presentation, I'll be discussing the current problem we're dealing with, a product demonstration, competitor analysis, and business strategy. Let's begin. Knee pain and instability. As OA patients become less active due to joint pain, their quadricep muscles atrophy from disuse. Up to 60% of the maximum torque in the knee extensors is lost, impairing activities that rely heavily on the quadriceps, like climbing stairs or standing from a seated position. This loss of functional independence results in poorer mental health and decreased quality of life. Patients who undergo knee replacement surgery are not spared, as quadricep atrophy also impairs their postoperative recovery. Even with a new joint, patients cannot walk if they do not have sufficient muscle power. This delays early mobilization, which increases the risk of surgical complications and slows recovery. But why are we talking about surgery in early stage OA? That's because osteoarthritis is a long-term chronic disease, which is treated holistically over the course of disease progression rather than in individual stages. Reducing quadricep atrophy at an early stage will allow greater postoperative mobility, leading to better post-op results. Our primary aim was hence to create a device that can be worn by early-stage OA patients to slow quadricep atrophy, improving quality of life preoperatively and postoperative surgical results. We reviewed the muscle power and movements of patients with osteoarthritis, and we realized something. Even though knee extension is difficult, like in climbing stairs or standing up from a seated position, knee flexion is easy. Gravity, body weight, and hamstring muscles assist in flexion. This is backed by data as a peer-reviewed meta-analysis of 5 different studies concluded that patients recovering from a total knee replacement have more quadricep atrophy than hamstring atrophy. And I quote, "Early rehabilitation should focus on recovery of quadricep muscle strength." So we thought, what if during this easy phase of flexion, the patient's knee stores energy for it to be used during the difficult phase of extension? And with this idea, the Neoknee was born. We created the Neoknee to complement existing treatment modalities. All symptomatic OA patients can use the Neoknee for rehabilitation. It decreases pain, improves postoperative results, and increases mobility. It's a uniquely designed brace that has a powerful spring running along its side. During knee flexion, this spring stores energy, which is redistributed back to the patient during extension. Imagine bending a tightly coiled spring and then releasing. That spring rebounds with a force. By leveraging this force, the Neoknee gives patients a mechanical advantage, decreasing load on the joint and the quadriceps, reducing pain. The spring can store up to 18 kilos of force to give patients power when they walk, the equivalent of offloading 60% of body weight in a 60-kilo user. The tension of the spring can also be tailored according to patient needs, adjusted to quadricep strength. I want to show you the power of the Neoknee. This is before, and this is after. I know it looks effortless, but she's lifting 30 kilos with an isolated movement per leg, which is effectively squatting her body weight without previous weight training. We wanted to prove that it will help in day-to-day mobility, like getting up from a chair. This is with and without the Neoknee. As you can see, whether it's climbing stairs, getting up from a seated position, or just walking, daily activities will be easier for patients. Mapping a patient's quadricep strength over the course of knee OA will look like this. The moment the patient feels that walking is too painful and adopts a more sedentary lifestyle, their muscle atrophy accelerates. With the Neoknee, that atrophy slows. As the patient's disease progresses, we increase the support to ensure the patient can walk comfortably without resorting to a quadricep avoidance gait, treating the patient while indirectly improving postoperative results. Currently, the approach to improve functional mobility are weight loss, physiotherapy, and in severe cases, mobility assistance, but all of these have its shortcomings. Weight loss for patients in OA knee is only possible in non-load bearing situations. A prescription from doctors is walking laps in a swimming pool in chest-height water, which can be logistically difficult for elderly patients. Physiotherapy is useful, but compliance to sessions and home-based exercises has always traditionally been a problem. Lastly, patients may be prescribed mobility devices such as walking sticks or require assistance from caregivers. These can allow patients to transfer their weight to an external force, but the amount of support is not adjustable. You need a fine balance when it comes to walking aids. enough support that the patient is comfortable, but not so much support that their muscles are not properly engaged. Furthermore, many elderly do not like to be seen with walking sticks because of stigma, while relying on a caregiver leads to a loss of independence and caregiver stress. The neo-knee sits at the center of all these treatment modalities. As the patient's functional mobility improves, all other treatments are more likely to succeed. When a patient is able to move independently, it will improve a patient's mental health and baseline activity, both of which are considered barriers to treatment compliance in weight loss and physiotherapy. Furthermore, the neo-knee is able to provide the patient with a mechanical advantage. Tension control means we can give sufficient support for pain-free movement, which is critical to ensuring that the patient's quadriceps are working and not wasting away. Lastly, the neo-knee's discrete form factor is more likely to be appealing to those concerned about stigma. Our SWOT analysis summarizes our position. Our strengths lie both in our innovative solution while simultaneously having unparalleled speed and execution. Our product is HSA Class A, which means only a manufacturer's license is required. We have a ready prototype and successfully sourced for a manufacturer with both manufacturing capacity and licenses, and we can start production in as little as 10 weeks. The opportunity is massive because we're facing changing social dynamics. Our aging population is now healthier and wealthier, with both the vested interest and financial means to invest in their long-term health and functional independence. Of course, this project has its weaknesses and threats, and we'd like to confront them early. We know the team consists of university students without much professional experience, and we are bridging this gap with close collaboration with orthopedic surgeons to ensure our product will serve its purpose. Furthermore, physiotherapists can be considered threats as they focus on rehabilitation as well, but we should instead cooperate with them, as the neo-knee can improve their results. As we evaluated our competitors, we noted a clear gap in the market. The braces currently available in the market are focused on passive stabilization instead of providing the patient with active mobility. On the other extreme, you have exoskeletons, which are prohibitively priced at $40,000, unfeasible for our vision of day-to-day use. We validated this prototype by speaking to Mr. K.H. Poon, a physiotherapist for over 16 years, and Dr. Jeffrey Chew, an orthopedic surgeon who has over 20 years of experience in knee replacements, both of whom supported the idea. Dr. Chew specifically stated that functional independence was the most critical quality of life factor that treatment seeks to preserve, and there was nothing in the market which currently addresses this problem. Naturally, we know that in order to have a defensible edge and recoup development costs, we need to be ready to protect our intellectual property. We received advice from Winnie Thum, director of a boutique IP law firm, regarding this issue. After a few rounds of discussion, we have been greenlit that the device is sufficiently novel such that a patent is possible. Our intention is to proceed with filing immediately after receiving sufficient funding. The neo-knee was built by a team whose shared vision and passion for helping patients have allowed this idea to take shape. Victoria, Daniel, Shern, and I are medical students interested in orthopedics and geriatrics and engaged our advisors to refine the idea. Ryan is a law student and provided legal insight into intellectual property protection. Nicholas, although another law student, was fundamental to moving this from prototype to product through his experience in manufacturing. However, no matter how earnest the team is, we know we need industry support. We draw this from 3 different advisors. Firstly, Dr. Chew, whose insight and innovation experience has been fundamental to our prototype. Secondly, Mr. Poon's physiotherapy background gave us a detailed understanding of knee biomechanics in a patient with OA. Lastly, Ms. Thum, whose expertise in intellectual property law helps us navigate the difficulty of patenting products for the market. Moving on to business strategy. Our current strategy is a B2B model, cooperating with physiotherapists and orthopedic surgeons to distribute the product. We currently have agreements in principle with Center for Orthopedics and KH Poon Physiotherapy, who will act as our earliest distribution partners. Our current value-based pricing will follow industry standard of 50% markup on our prima facie $300 cost price, and profit margin will increase as the product takes off and order quantity increases. The market potential is huge, as the orthopedics therapeutics market is going to reach $11 billion by 2025, up from $7.3 billion in 2020, supported by 650 million patients with OA. Locally, half of Singaporeans have reported chronic knee pain, and even with a conservative 5% conversion rate, financial projections strongly support the neo-knee's viability. We've planned a roadmap for the next 5 years. 2021 will focus on patent application and pilot studies to obtain further grants and pre-seed funding. The next 2 years will be exploring clinical trials to test the feasibility of this product, funded by grants in Step 1. By 2023, we believe a successful clinical trial will allow us to launch locally into Singapore and begin to generate revenue. In 2024, we'll be looking to expand regionally into Southeast Asian markets of Malaysia, Thailand, and Indonesia. Simultaneously, we hope to adjust the product to work on a variety of other knee pathologies. Finally, in 2025, we plan to look even further beyond just support, developing pressure and force sensors for holistic data-driven rehabilitation. In conclusion, the Neo Knee taps into an exponentially growing market with an innovative product, coupled with a validated unique selling proposition to ensure the success of our clearly defined business strategy. Help us reinvent mobility together. Thank you.
Thank you, Matthew. Now I hand the time off over to the steering committee judging panels to raise any questions.
Hello, hi, this is Mayank. Thanks for a very nice. Can I ask, what is your plan in terms of validating that the device actually improves clinical outcome? You talked about different clinical outcomes, so I just wanted to get some. I think it's an early project, but I do want to see if you want those.
Sorry, so the question is how do we plan to run our clinical trials and validate the product, is it?
Yeah, I don't know the details of the clinical trials, but have you thought about demonstrating that it actually works and it actually improves?
Yes, so thank you very much, Doctor. I think that for our clinical trial, our primary objective will be looking at pre-op as well as pre-op quality of life as well as post-operative results. And during our clinical trial, we hope to run a randomized control double-blinded trial where we do a cohort study on patients with osteoarthritis, and we get them to wear it, and then we take the standardized questionnaire on their quality of life with and without the Neo Knee, with and without tension as well. Simultaneously, we hope to track these patients even after they finish their operation to see how the patients with the Neo Knee have performed post-operatively, how quickly they ambulate, how well they ambulate, as well as discuss with their physiotherapists and follow-ups to observe their post-operative recovery. And that's going to be the frame of our clinical trial. And the validation will come in that they have better quality of life pre-operatively, as well as better post-operative results because of reduced quadricep atrophy. I hope that answers your question.
Yeah, thanks.
Yep, thank you, Dr. Mayang. Next up, we actually have a question by Mr. Lai Yifeng. I'll be showing it on stage. Yep. Have you thought about the need to conduct clinical trials? Okay, I believe that you have kind of covered that as well. Do you intend to adopt evidence-based practice to further promote your product?
So thank you, Mr. Lai. That's a very important question. And yes, absolutely. As you can see in our last slide, we were actually talking that within this year, we'll be focusing on pilot studies, and the following 2 years, we'll be looking at clinical trials in order to execute what we just described, where we want to prove conclusively that the Neo Knee gives better outcomes in health, both preoperatively and postoperatively. And absolutely, we agree that evidence-based medicine is fundamental to what we are trying to do, not just in our practice of innovation, but also in practice of medicine altogether. And everything we've done, everything we like to study, is all backed heavily by studies. So I hope that answers your question.
Yep. If not, Mr. Lai, feel free to come onto the stage to follow up with the question as well. Next up, we have another question from Dr. Mary. There are many similar such braces in the market or in development. No competitive assessments was made on this. Can you share more about this?
Okay, so thank you very much for that question.
I'll now be sharing screen again.
Yeah. Taking a deeper dive into passive stabilization, we actually also have unloader braces, which were not mentioned in the competitor because of 2 reasons. But basically, these braces use passive stabilization to shift the weight of the knee from one compartment to the other. And these effectively offload the weight of the joint. And we're better than these competitors for 2 reasons. Firstly, these braces do not provide mechanical support, such as the OSA Unloader one. It doesn't matter if you're shifting the weight, if the effect of the weight is still the same. And only when you add the strength of contraction will you be able to help patients. In fact, it might even speed up the wear of the other knee compartment due to increased joint stresses. Secondly, and very importantly, the price point. The prices of these braces are exorbitant, between $2,000 to $4,000. The number you see there is based on USD. And although these aren't as expensive as the exoskeletons we previously cited, they're still outside the scope of normal affordability. What we are offering in the Neo Knee is a superior product at a lower price, and we go above and beyond the competition. Furthermore, we did our market study not just by researching what was available, but also by discussing with all of the professionals, such as Mr. Poon, Dr. Chew, and actually a whole range of others because we did our orthopedic posting last year, where we kept searching and trying to understand how these patients really work. And based on all of this put together, we have come to the conclusion that there's nothing which can really compare to our brace in terms of providing active mobility at an affordable price with tension control. I hope that answers your question.
Yep. Actually, on a similar note, Dr. Mary has a question as well. Why target Malaysia, Thai, and Indonesia? And I think the question is more about affordability, whether you have done any assessment to think if the patients can afford the $300 fees.
So thank you very much for that question. The primary reason for Malaysia, Thailand, and Indonesia was actually based on discussions with Dr. Chew. And the reason for this is because Dr. Chew has contacts within these countries because of the medical tourism industry in Singapore, which gives him exposure to patients who are more interested in all of this. And during the course of our development, he actually gave us the opportunity to speak to some of these patients, and especially for the patients who come over into Singapore for their medical tourism, they were willing to buy it. Of course, we understand that the type of patients who come into Singapore for medical tourism are going to be able to afford a much more premium price point. But based on this understanding alone, we believe that, based on the medical tourism alone, we believe that we can already obtain quite a large number of patients based on our discussions with Dr. Chew. You are absolutely right that we understand that in developing countries, a $300 price point will be quite expensive. But we're also looking at different ways which we can enter the market. For example, through insurance panels, as well as looking at any mobility device schemes which may be available in these countries. We believe that we're able to sell it strongly, that we're able to improve your preoperative results, we're able to improve postoperative results. Insurance panels will be more likely to pick up the product as well. I hope that answers your question.
Yep. And then for the next question, let me just combine both questions from Dr. Mary and Dr. Agatha as well. This is regarding testing and trials. So from Dr. Mary, for feasibility trials, please highlight the endpoints to prove value. And for Dr. Agatha, let me just show you on screen as well. What are some risks of your solution and how will you test for safety of your brace?
So thank you very much. Can I answer Dr. Agatha's question first? Could you put it up on the screen so I could follow?
Definitely. Yeah.
So yes, for the risks of our solution, we believe that after discussion with our physiotherapist and orthopedic surgeon once again, and doing our research, our primary risk will be how the patients will be able to, how much support we can tailor it at such that the patient's quadriceps aren't atrophying. And we actually have two approaches to resolve this problem based on our tension control. Effectively, our concern is that if a patient is maxing out his support from the get-go, his quadricep atrophy may increase because he's effectively using a walking aid. But the current prototype you saw on the screen is based on patient control, where the user himself tailors the amount of support he wants in order to ambulate comfortably. But we're also exploring a possible approach where it's controlled by an external party, like a physiotherapist. We're actually developing an approach where we can lock the spring within a range of tension and give selected access to physiotherapists and professionals like orthopedic surgeons to avoid the possibility of patients who are unfamiliar with their abilities either giving themselves too much or too little support. And this will all be tested in our pilot study. As for the safety of our brace, we'll be testing both approaches hopefully in our clinical trials and prove that with these approaches, we'll be able to show that we still have our improved clinical outcomes. I hope that answers your question. Now, Wei Tian, could you shift over to the other question? So for feasibility trials, the endpoints to prove value will be, as previously mentioned, preoperative quality of life, as well as postoperative surgical results. Preoperative quality of life will be measured by a standardized questionnaire, where we ask patients about their mobility, about their comfort, about their pain levels. And this is quite common already. And we can use a lot of these standardized questionnaires just by speaking to patients, and we compare it with and without the neonate. So in an early preoperative stage, we're already looking at, okay, patients are already saying that they're more comfortable, they're better off. Next, we're looking at the postoperative outcomes, where now we look at the doctors and physiotherapists. We're asking, okay, what day do they start POD, postoperative, which day do they begin ambulating? How quick is their recovery? What is the caregiver burden? Are they using any of, do they need support? How are their clinical outcomes? What's the risk of deep vein thrombosis? And all of these questions will help us prove quite convincingly, especially if they're all in our favor, that the neonate is able to help improve clinical outcomes. I hope that answers both of your questions.
Yeah, so to expand on what Matthew just said, from a qualitative standpoint, yes, questionnaires as we follow patients would help. But from a quantitative standpoint, which of course is key to any scientific process, the main gist of our whole product is, do we value add to a patient's daily function, to their ability to carry out with their daily lives? And so when you have functions such as getting up from a seated position or walking, or very pertinently for OA patients, climbing stairs, timing, are patients able to do these things faster? Are patients able to do these things more comfortably? Are they more fluid? What are the differences in their gait? So, for example, in a patient with, more late stage OA, you will see them a little bit hunched over. Their hands will be on their knees because their quadriceps are so weak. They need to push on their legs just to straighten it. And versus, let's say, with the brace, we would like to see so-called an improvement in their gait. What is their gait cycle like and how that changes? So those would be the things that we're looking out for in our feasibility trial.
Thank you, Victoria, for adding that to that. I completely forgot about the quantitative analysis, which will always be fundamental to what we're trying to do. I hope that also answers your question.
Yep. Next up, we have a question from Dr. Jasmine. Let me just show you on the stage. Can you elaborate the thoughts behind the value-based pricing you mentioned?
So thank you very much, Dr. Jasmine. This was actually with close coordination with, this was actually a question which we asked our mentor during the period of this. So the reason we say that, the reason we put this 50% value-based markup is because firstly, we believe that we're adding value to the patient. We're giving something which is unique and not available to other patients, available in the market right now. And 50% was just an industry standard based on very preliminary questions we asked. Secondly, we believe that because we are offering like such a novel and unique product and introducing it to the market here, we have the ability to command a larger profit margin than standard like cost plus pricing. And all of this put together gives us a bit more, makes us feel a bit more confident in saying that this 50% value-based pricing, even though it's completely prima facie, is just a preliminary suggestion of what we could explore. I hope that answers your question.
Yep. Without delaying any further, let me just show the next question on stage. So this is from Ms. Joyce. What is your investment quantum required, taking account of your clinical trials, product development, as compared to the 300 price tag? Then when will your break even be?
So thank you very much, Ms. Joyce, for this question. Is in terms of the investment quantum required, we're actually planning on funding that with grants. We are quite extensively researching grants right now, and there are things like the SG Startup Founder Grant, as well as other clinical grants within NUH and SGH, which we hope to explore. We also believe that we can coordinate with a lot of the important healthcare centers in Singapore, such as Center for Innovation in Healthcare in Alexandra Hospital, in order to assist us in finding the sufficient grants in order to execute this process. So with grants out of the way, how much is product development? And currently for product development, we've based on our discussions with manufacturers, the amount of tooling required will be $40,000 to tool out and prepare everything for the first batch. This step, we hope to look for investors as well as aforementioned grants, which will help us tide through the process. In terms of our break-even value, we actually did a few financial projections just looking at the Singapore market itself. And estimated financial projections are actually currently based on the local market. And they are based on the following assumptions. Firstly, there's an 11% prevalence of symptomatic OA in Singaporeans 18 and above. Secondly, there's currently a population of 4.89 million adults, increasing about 100,000 annually. Thirdly, we're having this retail markup of 50%. And lastly, at the very early stages of year 1 to 5 of 2022 to 2025, we're looking at a conversion rate of 1 to 2%. And our break even, although very optimistic, will be within 2022 itself, assuming that we're able to convert 1%, because 1% of 537,000 patients is going to generate us close to $2 million worth of revenue. I hope that answers your question.
Yep, with the last 1 minute and a half, perhaps you can just quickly go through this question from Mr. Joshua.
Okay, so thank you, Mr. Joshua. Yes, given that we're medical students, so firstly, the medical student is, we're not just medical students, we're also law students, and all of us are coming together as a team. Our primary objectives as this team will actually be running the clinical trials and validation studies and backing up everything which is medical. However, we've also explored the idea of engaging part-time CEOs and basically engaging professionals and CEOs to help us with this, to provide us with the relevant business industry experience in order to bring the product to market. However, this is all very preliminary, and our team is very determined. In fact, Nicholas himself has founded 2 startups in his past, which he's already exited, and they've reached very substantial numbers, and he did this with very good time control. And we're very lucky to have him with the team. But yes, we believe that in order to bring this product to market, we're not going to overestimate our abilities, and I'm not going to say I'm the best suited person for this product. And we believe that by engaging external parties, we'll be able to push this forward even further. I hope that answers your question.
Yeah, I think speaking more to our experience as medical students, I think it's good definitely to be aware of our limitations. Yes, we are university students, we are medical students. What industry experience do we have? And the thing is that Matthew and I and Ryan Tian as well, and a lot of our group mates, we previously have done like innovation projects, because this is something that we've always been passionate about. And an organization that Matthew mentioned earlier, the Center for Innovation in Healthcare.
Victoria,
which
please
is-
wrap up your Q&A.
associated of NUH. So we've learned a lot from them about who is going to take leadership and about how to time things and who are the best parties to lead us forward to bring this product to market. Thank you.
Thank you very much.
Thank you, team. Thanks, Team Neoni, for their amazing presentation. Just want to give them a big round of applause for all they've done today. Can we please invite them off of the stage and move forward with the next presentation? So thanks, team. Thanks for joining us today.
Thank you very much.
Thank you.
Okay, and with that, we're free to move on to the next team for today's final pitch. So the next team that we're presenting is Team Alright, and they'll be presenting on the topic of dementia. Yep.